Stroke Conference. Và xin cảm ơn bác sĩ Nguyen mời Thanh nói chuyện với quý vị. Rất tiếng Việt, Thanh không có giỏi để tất cả bằng tiếng Việt. Vì có nhiều chữ với khó dịch để chia sẻ người Việt sau khi bài sai. Đây là số của Thanh. Bữa nay Thanh rất là vui được nói chuyện.
Có dịch mà. Nãy giờ có dịch mà.
A basic challenge at best. The outline today is we'll take a look at the natural history of basilar artery occlusion, its pathophysiology, imaging selection, and review some of the trial data that came out and future directions. The origin of basilar artery occlusion disease and treatment takes place in Aachen, Germany, where Professor Werner Hacke and Hans Zoomer evaluated a series of patients and noted the very dismal outlook of these patients on medical management. They had 17 patients in this classic paper in AJR in 1983, 17 patients with basilar artery thrombosis, of which 10 died and only 1 survived for a 1-year period. But all patients had severe neurological deficits and died from secondary comorbidities. And medical management at that time, which was heparin and other antithrombotics, offered no therapeutic advantage. And this led to the physicians to look at other potential therapies for these patients, including insertion of a catheter into the vertebral basilar artery and injecting streptokinase at the time, which they found was able to open the artery and seemed to arrest the downgrade spiral of these patients. And so I dare say these findings paper was the birth of endovascular therapy for large vessel occlusion stroke back in the 1980s. When we look at the anatomy of the basilar artery, we can divide it into 3 sections: distal, basilar, which is of interest because the pathophysiology of the strokes in this location tend to be a cardioembolic etiology in the third, and in the middle segment, we tend to see atherosclerotic etiologies of occlusion in this territory, and you probably see very commonly in Vietnam and China. And here's an example of a patient with severe intracranial atherosclerosis. On this lateral view, this is the basilar artery, this is the pica. You can see a pinhole of the basilar artery nourishing the basilar artery, so you can imagine this patient being vulnerable to posterior circulation infarcts or symptoms. And so I lead you in a discussion of the imaging of posterior circulation stroke using the posterior circulation aspect score, which was devised by Dr. Volker Putz, who's now in Dresden, Germany, and Dr. Demchuk from Calgary, where they made a 10-point score to look at hyperdensities in the posterior circulation as a potential way to predict outcomes for the patients. And this is the corollary of the famous operational program or the CT score of the anterior circulation. And so what's different here is that there's score points in the relevant territory of posterior circulation, including the thalamus, 1 point if there's a hyperdensity on either side, the cerebellum, the posterior cerebral artery, the midbrain. If you have hyperdensity on either side, it will score you automatically 2 points, so it's higher scoring, and also the pons. If you have a hyperdensity in any part of the pons on either side, it automatically scores a higher level of demarcation of points. So what's of interest to note from this study was that not only do you see better posterior circulation aspect scoring with CTA source imaging, here is the example of one patient where on baseline density, if you look at this scan, there's a hyperdensity you can demarcate in the PCA territory, the left occipital lobe, you can see here. But if you get contrast in CTA source imaging sequences, you can see more hyperdensity, not only in the left occipital lobe, but also in the superior cerebellum and the quantum-mesencephalic junction. So here you would score the patient in PC aspect of 7 based on the same time frame because of better visibility on the source imaging data. And then as the patient's infarct evolves, you can see the conditions infarct becoming more apparent on the non-contrast head CT. The PC aspect score was also validated in the BASICS study, which was a very important prospective registry led by Dr. Futura. And here I draw your attention to the BASICS prospective path artery occlusion registry, led by Dr. Shinda, and also the late Christine Weiser, who worked together very closely. It was conducted between 2002 to 2007, so relatively recent in our history of modern medicine. They classified stroke severity as severe versus mild to moderate, severe being coma, locked-in. Deficit that was less than severe. Patients were classified by their treatment of antithrombotics, intravenous thrombolytics, or intra-arterial therapy, and they adjudicated their outcomes at 1 month. What was interesting in this study was that they found a poor outcome in approximately 68% of patients, poor outcome being defined as MRS 4, 5, or 6. And what's more interesting is that the results did not support unequivocal superiority of intra-arterial over intravenous therapy. And furthermore, what we found was that in patients with mild to moderate deficit in the prospective BASIC study, they seem to fare with worse outcome after endovascular therapy compared to intravenous thrombolysis, with an adjusted ratio of 1.5, and there was same risk of poor outcome for IVT or IAT in these patients with mild to moderate deficit. I draw your attention to what evolved from the prospective BASICS registry, and that is the BASICS study protocol for the randomized controlled trial. And so when you look at the history of this trial, it is very interesting to know how they initially planned the study. They initially planned the study with patients enrolling based on NIH scale of 10 or greater, and symptoms and signs compatible with ischemia in the basilar artery. What's also interesting is they used estimated time of the basilar artery occlusion. So you could have a patient who had a prodrome of dizziness or diplopia maybe a few hours prior or a day prior, but the estimated time onset of the basilar artery occlusion, meaning when the patient had their sudden demise, would be categorized as the actual onset of the patient. And so the BASICS trialists had planned a 750 patient study, very ambitious, and they had intended to look at an absolute increase of 10% in favor of outcome for intra-arterial over intravenous thrombolysis in these patients. However, several years into the trial, 4 years, in fact, because of slow enrollment, they had to expand the criteria to allow patients who had an NIH stroke scale less than 10 into the study. And this was despite knowing from their prospective registry that these patients with NIH less than 10 seem to fare worse with endovascular compared to intravenous thrombolysis. And so the question is, why do they do this? Obviously, they need to finish the study, but also at this time when they make the changes, the birth of endovascular therapy, i.e. the anterior circulation trial, started. And so perhaps we have over-exuberant enthusiasm, thinking that by enlarging the enrollment criteria, that we could still see a signal benefit. There's such a huge benefit was seen in the anterior circulation. And so this brings us to the two very important studies, the BEST trial, the randomized trial, and the BASICS trial, both conducted and just recently published. The differences are demonstrated as follows. The BASICS was an international trial from many countries, whereas BEST was an international randomized study for basilar artery occlusion led by investigators from China, Dr. Xin-Feng Liu and Dr. Rivera led the study. And what the primary outcome for these two trials is the same, 90 days MRS 0 to 3. And when we say, why is it 0 to 3, whereas the anterior circulation, we tend to look at MRS 0 to 2 as the home run for calling the study positive. And it's because MRS 0 to 3 may be just as acceptable for a patient. Patient has an MRS 3 that could be as good a home run for a patient who has a basilar artery occlusion event. And there's a difference in time frame in two studies. Basics was a 0 to 6 hour trial, best was 0 to 8 hours, a little bit longer. The years in which the trials are conducted are shown, which is relatively recent from our current day. And Basics was successful in completing the 300 out of 300 intended patients, again modified from the original 700 patients or so. And then Best has to stop enrollment after about a third of the patients were enrolled because of a high degree of crossover between the arms. What is important to distinguish between Basics and Best is that there's a very high degree of treatment of IV thrombolytic in the Basic study. Up to 80% of patients in both arms receive IV thrombolysis in Basic, whereas only a third of patients in Best, despite being similar time window, receive IVT. And so one can argue there are potential differences of these differences in treatment strategy. I.e. Best was a 0 to 8 hour trial, so maybe less patients enrolled because they were being enrolled later, or because of the philosophy of restructured payment in China, where some patients have to pay out of pocket for their medicine. The other interesting findings between the two trials is that Basics had overall crossover rate of 3%, very little, whereas Best suffered from higher crossover rate, 13%. Still impressive for a Basilar artery occlusion trial. You have to commend investigators for this. And in the medical group, 1 in 5 patients crossed over to EDT, which led to the cessation of the trial. So for primary endpoints, Basics showed a favorable functional outcome of 44% in the EDT group. So while it was numerically higher than the 38% in the medical group, it was not statistically significant from what they had predefined. For safety endpoints, symptomatic hemorrhage was numerically higher in the EDT arm, and mortality numerically lower in the EDT arm, but did not reach statistical significance. I would like to draw your attention to subgroup analysis in Basics, because I think this is important for us to understand a little bit about the pathophysiology and how do we conduct ourselves moving forward. So if we divide the subgroups based on NIH stroke score, i.e. NIH has 10, of which 60 patients were enrolled, we see that there was no treatment effect benefit for endovascular over medical care in this analysis. Again, this is all underpowered subgroup analysis. In the subgroup of patients that were NIH stroke scale of 10 or greater, you do see a signal of benefit that endovascular therapy was superior for these patients. However, this again is an underpowered analysis to draw any firm conclusions. In the Best study, what was the primary outcomes? Overall, in the intention to treat arm, there was essentially no difference in favorable outcome of MRS of 3 at 90 days between the endovascular compared to the medical management arm. I'd like to thank Dr. Gustavus from Canada, who invited myself and Dr. Struvian to comment on the Basics and Best trials and understand why was it that we see such an interesting difference between anterior and posterior circulation LVO. Why is it that all the anterior circulation studies were positive, whereas the posterior circulation weren't? And what can surmise several hypotheses that we illustrated in our editorial on stroke? And one of the potential reasons may have to do with the efficacy of intravenous thrombolytics in the posterior circulation compared to anterior circulation. And so I draw your attention to this famous paper by Christian Reidel from Germany, who looked at clot length and the success, or the chances of success of opening the artery with intravenous thrombolytic, such that if you had a clot that measured 8 millimeters or greater, that you almost have zero chance of opening this artery on follow-up or patients with middle cerebral N1. And so fast forward, you look, or fast backwards, and you look at Daniel Struvian's study. He led this in Helsinki, where they had patients who had variable clot length in the posterior circulation that they measured, and the probability of recanalization was much higher.
That is, if you had a clot less than 10, up to 80% chance of opening the artery, which is quite impressive. And if you had a clot greater than 10, you had a 50 to 70% chance of opening the artery, which is truly remarkable. So, moving on, this makes the argument for intravenous thrombolysis for posterior circulation very interesting. And it brings us to the next kid on the block, that is tenecteplase, which is the newer thrombolytic that has been studied very fervently in the last few years, especially from Australia. And so our colleagues from Melbourne, Dr. Alemseged and Dr. Bruce Campbell, looked at a series of patients who underwent treatment of basilar artery occlusion with tenecteplase. And similar to the anterior circulation, they also noticed higher reperfusion rates among those who had basilar artery occlusion and were treated with tenecteplase, 26% reperfused compared to TPA 7%. So very similar to the anterior circulation data from Extend IA-TNK. And again, no difference in symptomatic hemorrhage between the TNK versus TPA. And obviously you saw shorter IVT to puncture times in the TNK treated patients because these patients got a bolus and then went to angio, whereas the TPA treated patients got the bolus and then got the infusion. So, where does this lead us to? The basilar artery occlusion Chinese endovascular trial is ongoing to look at the answer, does basilar artery occlusion thrombectomy work for 6 to 24 hours after symptom onset, and they're enrolling patients with NI stroke scale 6 or greater. And there's another Chinese trial looking at basilar artery occlusion for patients up to 12 hours, but with the subgroup of patients NIH 10 or greater. And this brings us to new frontiers of posterior circulation thrombectomy. As you know, distal and medium vessel occlusion is a strong area of research and of new randomized trials that are being built as we speak. And so we evaluate this mechanical thrombectomy and isolated occlusion of the proximal posterior cerebral artery. We don't know if it's better to do medical management or if it's better to do endovascular therapy. In this patient we treated with isolated hemianopsia. We took out with a stent retriever. And so the answer remains to be seen. And if we're trying to even push further the frontiers, we've also looked at mechanical thrombectomy of the fetal posterior cerebral artery, which my partner Mohammed Abdelkader published recently in the new stroke journal, Stroke Vascular and Interventional Neurology in November 2021. Again, one can argue that fetal PCA is of the anterior circulation because of the embryology. As you see, this is a fetal circulation, but it is still, in some respects, classified as a posterior circulation based on its geographic disposition. So in conclusion, we are back to the drawing board for basilar artery occlusion. We still don't have a positive trial. There are 2 trials ongoing in China, and one can surmise some of the reasons for failure of our basilar artery occlusion trials being the high degree of crossover, the enlargement of enrolling criteria of patients with low NI stroke scales, and also the question is whether every eligible patient was truly enrolled that was eligible to be enrolled in these trials. Moving forward, if we don't have a trial or the luxury of a trial, like they do in certain areas in China, what do you do with a patient who presents to you with basilar artery occlusion? I understand there's very strong perspectives from our Vietnamese colleagues, but for patients with basilar artery occlusion and low NIH stroke scale, medical management should be performed, and it did outperform or perform better than expected in basics. We have an escalation in controversy of using medical versus endovascular therapy for this subgroup of patients, and the question is whether tenecteplase can confer additional benefit compared to TPA in this location. For patients who present with basilar artery occlusion and high NI stroke scale, one would recommend to treat with intravenous thrombolysis if eligible and monitor the patient closely. If there is deterioration, then one would consider endovascular therapy. After the publication of our editorial, Dr. Jens Fieler from Germany emitted this tweet, thoughtful analysis, simple thought, endovascular therapy for basilar artery occlusion has been utilized in Germany since 1981. There is no signal of IVT superiority from best or basics, so opening the artery is the answer. Thanh xin cảm ơn quý vị đã nghe Thanh nói chuyện về basilar artery occlusion và sẽ mời quý vị hỏi câu hỏi in the Q&A section. Ok, cảm ơn quý vị. Chào.
Bây giờ chúng ta sẽ bắt đầu cái câu hỏi, tại vì để cho cái giáo sư Thanh Phan chấm dứt trước khi chúng ta nghe cái giáo sư Louis Kaplan báo cáo. Các đồng nghiệp có câu hỏi nào về cái tác động mạch thân này không ạ?
Cho tôi hỏi giáo sư Thành Nguyễn một câu. Vâng, trong các cái tuần hoàn sau tác động mạch thân nền chẳng hạn đấy, điểm nhích thấp. Thế thì bà cho biết cái vai trò của chẩn đoán hình ảnh trong giai đoạn trong này như nào, nên dùng CTA hay là sẽ dùng MRI? Xin cảm ơn.
Thì chúng tôi dùng CCA là vì CCA dễ thì khi cục mặt của lẹ hơn là lúc mà quý vị có MRI và nó tràn lẹ rồi thì cứ làm MRI không sao, nhưng mà CCA cũng được. Nếu mà trẻ nó không sao hoặc là 12 đến 21 tiếng hồ thì quý vị còn có úp dụng được MRI thì cứ dùng MRI thì có thể là cái gì biết không suốt đã chết rồi để gặp những part that after the decision making judgment của quý vị.
Các đồng nghiệp có nghe rõ câu trả lời không ạ? Tức là trong vòng 12 giờ đầu thì chúng ta sẽ chụp CTA, bởi vì CTA nó nhanh, nó fast. Trong trường hợp bệnh nhân mà sau 12, 24 giờ thì chúng ta chụp MRI, bởi vì chúng ta thấy được cái nhu mô của cái vùng thân não. Các đồng nghiệp còn câu hỏi có hay không ạ? Dr. Thanh, I have a question for you. You hear me, Dr. Thanh? We don't have a strong evidence for extend window for basilar occlusion, even with the TPA or thrombectomy. But I think a lot of doctors, include me, strongly believe that we can do extend window for thrombectomy or even thrombolysis for the patient come with us in extend window, maybe 12 or even 24 hours if we have evidence to show that the bond tie is still there. How about the current practice in USA? Thank you.
We share chúng tôi Việt Nam như là bệnh nhân chiến lược therapy thì chúng tôi sẽ go for it. For I thì cái này cái data hơi mới thì chúng tôi áp dụng như là họ áp dụng ở Germany, Vegas. Đó dùng anterior circulation stroke of the night circulation wasn't very well represented for the extended trials. So we would hesitate to decide in such a late window, but probably not in the therapy.
Can you repeat? Can you repeat by English, please? You can do for you can do for thrombectomy for a patient with extend window with basilar occlusion.
Yeah, we would be pretty aggressive on pursuing or offering to the patient or their families in the vascular and the late window if presented as severe deficits, because the alternative we believe is that with medical management that they may endovascular inlet window if you think that there is potential self-mobility.
Tôi có hỏi bà về chúng ta chưa có những cái chứng cứ mạnh về cái việc chúng ta mở rộng cửa sổ thời gian đối với tắc động mạch thân nền. Thì tôi hỏi bà mặc dù chúng ta không có chứng cứ như vậy thì chúng ta có thể mở rộng cái cửa sổ thời gian đối với tắc động mạch hay không? Thì bà có nói rằng đối với những bệnh nhân mà bà nghĩ rằng nó sẽ có lợi thì chúng ta có thể chấp nhận việc chúng ta mở rộng cái cửa sổ thời gian cho các trường hợp tắc động mạch thân nền. Các đồng nghiệp có câu hỏi nào?
Cho tôi hỏi bà một câu nữa. Vâng. Cho tôi hỏi giáo sư một câu nữa là trong cái tắc của động mạch thân nền ấy thì có thể tắc đầu, đoạn động mạch thân nền, tắc giữa và tắc đoạn cuối. Thế thì theo bà thì cái tắc đoạn nào thì nó nguy hiểm hơn và có thể dùng cái dụng cụ stent nào khác không? Vâng, xin cảm ơn.
Distal occlusion, which one? Yes. Can you hear me? Can you hear me? Hello.
Alo. Tôi hỏi lại hả? Tôi hỏi lại một chút ạ. Vâng. Trong cái tắc động mạch thân nền thì nó có tắc của 3 đoạn: đoạn đầu, đoạn giữa hoặc đoạn đỉnh động mạch thân nền. Thế thì
Nguyên chưa bắt đầu bài của cấp lăng mà.
Thế thì theo bà thì có phải dùng dụng cụ gì khác không? Hoặc là cái tiên lượng của tắc từng đoạn động mạch như thế nào trong cái can thiệp mạch?
On MRI that these patients can have some meaningful recovery in later months. So those are case report levels, but it does make one feel compelled to offer to the patients that they're having everything it takes to potentially rescue these patients if we think there's potential salvage. But you're absolutely right. If there's a complete whiteout, the chances are that's good, but they're not zero because some DWI can be reversed. I just want to make sure I answer the other questions. There's still time to answer the last question.
Đã hết giờ, thành ra để cho bắt đầu cái. Sorry, we don't have time's up now. Thank you very much for joining us this year, Dr. Thanh. Merry Christmas and Happy New Year for you and family. And we wish we can have you in next time in Vietnam. Thank you very much for joining us this year.